Bonjour tout le monde. Good day, everyone. Welcome to today's online event featuring knowledgeable speakers on how healthy are newcomer children, nutritional concerns, and healthcare access among immigrant children in Canada, presented by the National Newcomer Navigation Network. Before we begin today's webinar, I'd like to begin with a land acknowledgement that N4 is hosted at CHEO in Ottawa, Ontario, Canada. Ottawa is built on unceded Algonquin and Anishinaabe territory. The peoples of the Algonquin and Anishinaabe Nation have lived on this territory for millennia, and we honor them and this land. Their culture and presence have nurtured and continue to nurture this land. N4 also honors all First Nations, Inuit, and Métis people and their valuable past and present contributions to this land. My name is Andrew Tomeyer. I go by the pronouns he, him, and I am the Education Coordinator with the National Newcomer Navigation Network. I will be hosting and moderating today's presentation. My co-host is Mariah Maddock, who will be monitoring the Q&A box today. I'm pleased to introduce you to today's speakers, Dr. Ginny Lane and Dr. Hassan Vatanparast. Dr. Ginny Lane is a registered dietitian and an adjunct professor with the School of Public Health at the University of Saskatchewan. She's worked in a variety of community development, government, and health system settings. She's currently engaged as a scientific writer with the Canadian Academy of Health Sciences, working on the National Autism Assessment. Her research interests include sustainable development, food security, chronic diseases, disabilities, dementia, and health promotion with a focus on children, seniors, and vulnerable populations. Dr. Vatanparast is a professor with a joint appointment to the College of Pharmacy and Nutrition and School of Public Health at the University of Saskatchewan. Hassan is actively involved in research and health promotion initiatives targeting mainly the health status and access to care for newcomers, particularly children. Hassan is leading several research and health promotion initiatives at the local, national, and global levels aimed to improve the nutritional health of newcomers, particularly refugees and Indigenous communities as well. Hassan and his co-researchers benefit from multi-sectoral collaboration in these initiatives. The team has published several papers as well as presented their findings at national and international conferences. Hassan and his colleagues continue their collaborative work with the goal of improving nutritional health of at-risk populations. Today's session is being recorded and will be uploaded to the N4 platform within 24 to 48 hours following today's presentation. Should there be any technical issues during this webinar, all attendees will be informed with details on an alternate makeup session. Before we begin today's event, I would like to take a moment to introduce you to our platform features to help enhance your participation experience. Throughout today's session, we invite you to write your questions in the Q&A window. If you would like to direct your question to a specific presenter, please include their name at the start of your question. We will be monitoring these questions throughout the session. We know sometimes many of you might have the same question or be interested in a particular response, and so there is also the option to upvote a question. Please upvote questions you're interested in hearing the answer to, and we will prioritize which questions we pose to the speakers first. Our speakers today have no conflicts of interest to declare, and so I'm passing the virtual podium over to Hassan and Ginny. Thank you.
Okay. Hello, everyone. Allow me to share my screen with you. Still, I have some challenges with learning how Zoom works because we are using different platform in our regular sessions. Okay, so thank you very much, Andrew, for the introduction, and thank you for this opportunity to present what we have done related to immigration health to the audience, and also thanks to the participants for this talk. Before I start, I have some acknowledgements to make. Definitely the work that I'm presenting is not the sole work of me. There are many people participated. You see some names in here, Dr. Lane, Christine Smith, and others. I'm not gonna go through them, but I am presenting on their behalf. Also, our projects had benefit of collaboration with around 30 NGOs, immigrant refugee families, and partners from 15 universities in Canada and across the globe. Also, different funding agencies have funded our projects. As Andrew mentions, we have no conflict of interest. And also, I'd like to acknowledge that in Saskatchewan, we live and work on Territory 6 and the homeland of Métis. So just quickly going through the objectives of this talk, I'm going to quickly go through nutrition and health status of newcomer children. and to organize the differences in nutrition and health status of between immigrants and refugees and compare them with Canadian counterparts. Before I start going through the topic, Andrew, can you please share the poll results?
All right, just a few more seconds before I close this first poll. Okay, polling is now closed. Okay,
we have 39%, 7 people, healthcare providers for newcomer families, settlement agencies, 4 people, academics, 5 people. This is great. And also, do you have any experience providing services to newcomer children? 11 of you have experience. This is great. Thank you. Andrew, can you please go to the second poll?
Okay, I will close the poll in the next couple seconds.
Okay, so there is no difference. Immigrant children are healthier than refugees, 65%. So you have the points. I guess we are done with our presentation. So you are already very much familiar with the topic. Just perhaps refreshing what you know and what we have learned from our own research. Thank you, Andrew. Now, moving forward, definitely you know that we have healthy immigrant effect. There are immigrants, refugees, not refugees. Overall, immigrants are healthier at the point of arrival, but it takes only 2 years to enter to some health problems. And then within 4 years, they are entering to poor health. So it's around, say, 3 times higher than where they were before. And then also objective measures show declining in health status of newcomers. So these are concerning situations. What is happening to them when they come to Canada? You all should be familiar with the fact that you are in here, and based on the polls, you are familiar with acculturation. That's the process by which immigrants adopt the new culture. There are different theories describing acculturation. So the most common one is the linear one, that you are losing your own culture, gaining the new culture. The other one that I like it better because it's more comprehensive is talking about a bicultural model. Basically, you can have both cultures in some degrees. And there are 4 situations in here. No matter what, entering to a new culture causes some conflict, anxiety, and then original culture is going to be diminishing. And why this is important nowadays, because the patterns of immigration these days to Canada is in a way that most people around the globe that are coming to Canada are coming from different cultural, language background. We have another poll in here, right, Andrew?
Okay, we're just going to give it a couple more seconds and I will end the poll.
So definitely, this is what we discussed in the previous slide, and it's obvious that their health status is declining over time. Thanks, Andrew. Can you please go to the next question? So we're talking about acculturation. Before I enter to the next slide, I'd like to hear from you. Who are the people that are more susceptible for acculturation?
And I'll just give it a few more seconds and I will end the poll.
Definitely, and you know better than me that, oh, thank you very much, Andrew, that children are much more susceptible for acculturation. It's happening in them very quick. And then among acculturation, one of the areas that we are focused on is dietary acculturation, basically adopting the dietary practice of host countries, happening very quick in them. The picture that you see is a session that we have with newcomer children in one of our settlement agencies. So as you know, acculturation is happening in young age. There are different reasons for that when it comes to the whole family, not just children. Traditional foods are expensive, not available. Basically, it's not the case for Montreal, Vancouver, Toronto, or big areas that we have a community for different cultural backgrounds. Western food are high in fat and sugar and so on, and then newcomer children are easily influenced, and then parents, again, it's convenient for them, it's easy for preparation, even it's cheaper, and then they go to the direction. The results in is chronic diseases. So acculturation and health, if you look at what's the results of acculturation, there are different diseases that are listed in here based on evidence, from obesity even to depressive syndrome. So this is a huge range of health issues are entering with acculturation to newcomers. So why we are focusing on children? Because most of the studies that looked into immigration health look into the adults. We do not have comprehensive studies in children looking at immigrant refugee in separate groups. And basically, we know that the healthy immigrant effect is basically shows what is happening in adults. We don't know what is happening in children. And also, right now, we are dealing with two major phenomena: globalization and nutrition transition. So one side we have acculturation, the other side nutrition transition. How these two are interacting or working together toward having unhealthier children. So that's why we decided to work on children. This picture is showing one of our activities in our classes with refugee, Syrian refugees. And it was an amazing set of activities that we had at University of Saskatchewan. So with that background, we decided to design a study called Healthy Immigrant Children Study. This is a study started in, I believe in this picture is taken 2012. It's around that time. It's a very comprehensive study. We have had several publications based on that. The whole idea was to characterize health and nutrition stats that affect newcomer children. What a study design, we tried to use a mixed method design, a very comprehensive version of mixed method design, collecting both qualitative, quantitative data. And around 303 children, looking at the age, overall around 8 years of age. In terms of male-female distribution, almost a fair distribution between male and female. And looking into region of origin, most refugees came from South Asia. Most immigrants came from Middle East, as we see. This is the pattern right now. But before this data were collected, before we have the wave of Syrian refugees in Canada. In terms of education level, you see that this is the blue one is less than high school, and then we have high school diploma and university. When it comes to immigrants, we have most of 30% of them and 28% mother and father. They have university level education. When it comes to refugee, most of them are in the category of less than high school diploma. What about the income cutoffs, immigrants versus refugees? Immigrants from now on are blue and refugees are in orange. You see that refugees, 77% of them are below the low income cutoff that we have in Canada. Stats Canada, if you look at their survey data, they have different pictures. So for newcomers, they have 18.4%. There is a reason for that. So then with those statistics, we know that why immigrants and refugees are different. Basically, immigrants have choice. They are ready. They get preparation for moving to a new country, but refugees, everything is happening so quick. They have no time. Usually they are living in rural communities, and they just need to take the first thing that they can take with them and leave their home. And these pictures are taken from Syrian refugee wave that we had. And you have all heard those sad stories, what is happening for refugees. We looked into nutritional health. We basically collected data using 24-hour record, which is a very comprehensive tool for assessing diet. Healthy eating index, this is the index that we use to see how healthy is eating pattern of children and adults. If we look at most of them are in the category of need improvement, immigrants, refugees, and also Canadians. So this is something that at least we can say that there is a commonality. The main difference is in poor category, that we have 14% refugee children in poor category. Now let's move to food group intake. These are main food groups that we had based on the previous food guide, not the most recent one. You see that prevalence of inadequate intake. 83% in here in refugees, 77 comes to 83% and 76% for refugees. They do not meet the recommendation level at that time for these two main food groups that are important. Then, so why this is happening? If we go to our qualitative data, the issue of income is really important. They were in a situation when they were in assistance program, they were able to buy big gallons right now, just 1 liter, and then basically they can't get that much. Looking into the patterns of beverage intake, sugar sweetened is in here and milk is in here, milk-based beverages. Canadian boys in here, Canadian girls, immigrants, and refugees. In both categories, you see that immigrant refugees are a bit lower than Canadians in terms of daily intake of sweetened beverage and milk-based beverages. And refugees definitely are less than other groups. And asking them what's the pattern of intake in children from moms, yes, the tendency to go to junk food, fast food, chocolate, and then the kids are getting angry if parents don't buy what they need. Now, moving forward to prevalence of inadequacy in nutrient intake. Looking into some key nutrients that are really needed for growth and development, 82% and 79% for refugees and immigrants, you see that they do not meet the recommendations for calcium intake. When it comes to vitamin D, it's huge. 96% of refugees, 86% of immigrants. Zinc, 36% for refugees. These are really concern. For vitamin D, this is a concern for all Canadian children at that time. But say zinc and calcium show itself very well, and also folate. So kind of looking into going one step further, looking at the blood samples, what's their vitamin D status in their blood. Here, the pink part of the graphs are the part that they are deficient. Basically, they need the clinical intervention. You see that immigrants, 15% of them, refugees, 26%. When it comes to refugees, 46%, they have insufficient. And when it comes to Canadian children, 78%. For Canadian children, we use data from Canadian Health Measure Survey. And here is another kind of evaluation, what is happening with vitamin D status. As you see, compared to, say, compared to boys, girls, immigrant girls, they have significantly lower vitamin D status. And if you look at these values compared to general population, non-immigrant, significantly lower. So what are the predictors of serum status? High vitamin D status, younger newcomers, higher intake of vitamin D, those who are coming with a wider skin originated from Western Europe and United States. So what about the bone mineral content? We know that childhood is a golden period of time. Childhood and adolescence is a golden period of time for us to build bone for later in life. 38% of immigrant children, 44% of refugees, they did not reach to desirable level of bone for their health. I mean, for desirable for their sex. This is again huge number. What are the predictors? So definitely those who had those who were taller, they had better bones. Those who were food secure, higher vitamin D level, and greater amount of calcium, lower body fat. These are things that basically everybody can make sense of it. What about physical activity level? We have 60 minutes per day physical activity requirements for children. 28.5% of participants, they did not meet their requirement. Older children, 83% of them met. When it comes to younger children, none of them met. Males were more active than females, and 33% and 49% of immigrants, 49% of refugees spent more time for sedentary activities. Basically, they had too much screen time. Considering this last year, during pandemic, definitely this screen time has increased. Now, moving to food security status, as you see for all interviews, we have the interviewer, and then we have an interpreter to make sure that we capture issues with language. If you look at the national survey data, new Canadians, 15% food insecure compared to general population. Long-term immigrants and general population are very similar. So our study showed that 61% of refugees, 82% of immigrants, they were food insecure. And why this discrepancy? The main reason is that national survey data, they exclude those who cannot speak in English and French. So basically they exclude those who are much more at risk. They have language barrier, they can't get job. Definitely they put them away, and then they go to those who with language, you can do many things. And this is the main challenge for immigrants. And also they do not differentiate immigrants from refugees, kind of overestimating the food security status. In a different study, we looked into Syrian refugees, and we found food insecurity in much higher level in refugee children, in refugee families. This is overall sample. Refugee families compared to other samples that we had. Yesterday, we did finalize the analysis on bigger sample from 2 provinces. This is 2 cities. 77% food insecurity at household level. When it comes to children, is over 50% food insecurity for Syrian refugee children, and these are all concerning. So what would be the impact of food insecurity? Definitely it has impact on early establishment of chronic diseases, and mental health issues, and infection, and so on. So you can name it. There are many different diseases that may have impact. So looking into our qualitative data, we see that poverty is playing major role in here, and the influence that they get from food environment, the school environment, and also issues with transportation and so on, that they need to have the migration process that they need to pay, so they won't have that much funding available. This is a quote from Regina healthcare provider you see from high school. There says that lots of Filipino immigrants, and then they are embarrassed to take take out their lunch in front of their peers, and because somehow it's smelly, and then they are hiding that. I have heard this kind of stories from many teachers in the school system in here for primary and high school. I'm going to go to kind of measures of health status, overweight and obesity. It was almost similar at that time with what we see in Canadian population for immigrant children, but not refugees, around 31%, and overall prevalence of overweight and obesity. Comes to waist circumference, again, we are concerned about that, as you know, that the fat in belly is more metabolically active, and then it may cause more issues in future in terms of diabetes, cardiovascular disease, and so on. So we see that 54% of immigrants and 22% of refugees, they had much higher level of abdominal fat. Predictors of obesity: older age children, poorer quality of diet, and then higher education in parents. Again, this is something that creates some kind of controversy. Now, comes to standing, and immigrants, you see 5%, refugees 22%. So these are all shows that how immigrant and refugee children are different from each other. Qualitative findings, say change in diet, say genetic predisposition. We have seen that in different studies: mental health issues, lack of knowledge about chronic diseases, and then food deprivation, and then there are different factors that comes from our study and other studies as well. Cholesterol level, this is something that I personally didn't expect to see that. So looking at high for age and sex, you see that refugee children 28% higher cholesterol than what it should be. Immigrants 8%. Again, comes to the choices for refugees, poor choices compared to Canadian children, similar age group, 35%. Or in borderland, they do not have anybody in high, but we have, and this is based on national survey data. Predictors of high cholesterol level, refugee children, and higher saturated fat intake. So basically what we see in the diet of children and the physical activity, it makes the path ready for early establishment of chronic diseases for them. This is what we expect to see in future. And we have many studies, including one of our own studies in Canadian children, showing that dietary habits that are established in childhood are maintained, likely are maintained to the adulthood. And then imagine you go this way of eating for a long time, definitely you're going to be entering to health risk in future. Also, it's very interesting that we found in one of our own studies, longitudinal studies, that healthier dietary habits established in childhood are maintained to adulthood. This is really important. So that's the time for intervention. So going to concluding remarks, newcomer families might be at greater risk of experiencing health issues, and newcomer children, particularly refugees, are at risk of food insecurity, high prevalence of vitamin D, these are highlights, and also issues with key nutrients, and high prevalence of overweight, obesity, and the situation getting worse in Syrian refugees. And something needs to be done, and different levels of interventions, and this is something that perhaps N4 can work on it in future with other partners across the country. I put this slide in my talks at the end because I like to bring ourselves in the shoes of a person who is working with children, newcomer children. We didn't have time to talk about culturally appropriate care, but I like us to think about what I'm doing in terms of my job and what I know and what I need to learn, what I will do to make change in newcomer in health status of newcomer children. And that's the end of my slides. Thank you for your attention.
Thank you, Hassan. We will pass it over to Dr. Ginny Lane.
Hello, everybody. I think, Hassan, you just need to quit. Oh, you're quitting. Good. Okay. So we'd planned that I'd have about 20 minutes, so hopefully we'll get through that and have some time for questions. So Hassan provided, the basic background around health status and such. And so now I'll get more into the actual accessing of healthcare and what are the issues for immigrant and refugee families. And so the research that I'm presenting here to you today is based on the study which Hassan provided you some background about. And it's based on the interviews that we did with parents, about 20 refugee and immigrant parents and 25 service providers. So this first slide provides you with an idea of the number of responses that the either the newcomers or the service providers provided that were based into various categories of barriers of access to healthcare. And you'll see that access to health benefits is one of the big ones there. Both service providers and newcomers both recognize that. And so that means access to usually provincially regulated benefits like low-income benefits for people to access dental care or eye care for their children or lower cost drugs. And then one of the other big ones was navigation difficulty, meaning not knowing where to go for services, experiencing lots of difficulties in figuring out the system. And you can see both newcomers and service providers recognize that. And language and low literacy was very similar. Both groups recognize that, although service providers quite a bit more recognize that, likely because of their interactions. And then you'll see that that service limitations and stigma appear to be a fairly big block for newcomers themselves, meaning that they see that issue in that, some services aren't meeting their needs or they don't feel comfortable in going to some services. And then the smaller one related to gender and cultural concerns, you can see that newcomers themselves didn't often identify that, but service providers are certainly aware of that. So I just wanted to bring that out into the picture because sometimes when we think about how to provide better care to newcomers, we go right towards the gender and cultural competency. And that's not always the issue, although it's certainly important. There's lots of other ways that we can look at our health system and how we can do better. So I'll go through a few quotes related to these various themes that we identified. So the first one is around awareness of services. So when the newcomer comes here, they don't know where they can go, what they can get for their problem. Mostly they are not aware of all these things until one day they have a problem and they start knowing after having the problem. Meaning that they often don't get proactive information about what the services are so that they can really understand the healthcare system and where they should go when they eventually do have a problem. Our system is not obviously serving them better at the front end. Concerning health attitudes, a healthcare provider notes this, that they don't often have the knowledge about health prevention. As long as they are healthy, they don't go see a doctor. There is something called prevention and they don't have that idea. They wait until they are too sick to work before going to the doctor, up to the point they rely on more traditional cultural ways of maintaining their health. So this is just an understanding from a healthcare provider that many newcomers they see don't come until they're really very sick. They aren't used to seeking preventative care. And this may be because they lived in a very resource poor area where that wasn't possible before. Now they're in Canada and we do have the opportunity to do preventative care, go see your doctor to maintain your good health rather than wait until you're very sick. But that takes a change of habits and they may not have had that from their past. Related to chronic disease, a provider mentioned that most cultures think that the doctor gives me this medicine. When it's done, I will feel better. A lot of cultures don't know there is something called chronic disease, and they have to take medicine for a long time. Sometimes people have come from a culture where when someone gets sick, they either recover or they die. And they haven't really observed, chronic disease process, having diabetes for a long time. And don't thoroughly understand that you really do need to either follow your prescribed diet or take whatever medications have been prescribed for you, possibly forever. It's just not that understanding for some people. So this is a refugee telling me this, that his wife eats normally, just avoids sweets. The nutritionist talked to her about food also, but we forget. Only remember, eat healthy food, vegetables, milk, sandwich. She takes pills and she needs to check her glucose test. She loses weight all the time because she doesn't want to eat a lot, just eat a little to lose weight. And so, it may seem kind of innocuous, the quote about losing a bit of weight, but when you're diabetic, you don't want to be losing weight all the time. You want to be pretty stable to make sure that you're taking the right amount of medication for what you need. And so it illustrates that the depth of understanding around how to manage chronic disease may not be apparent for everybody. Relating to stigma, a healthcare provider mentioned that sending these people to mental health was a big challenge, and with the stigma, they wouldn't show up for their appointments. We have a psychiatrist who comes once a week to see our patients, and for those families, it is good to say that I'm going to the primary healthcare clinic. Their husband will accept that. Community and society accept that because they are seeing the physician. Patients are coming and going to counseling. So it just illustrates that there are some services for which people are reticent to go, including mental health or perhaps other services as well, and that we have to look at different ways of integrating that service so that it's more acceptable to go to. Regarding language and low literacy, a service provider mentions that they have to go with an interpreter to learn about diet. If they don't understand what to do. They keep eating what they have been eating. If there is a very complicated health issue like high blood pressure, cholesterol, blood sugar, many need help to go see their doctor very often. It's frustrating for families. So it just illustrates that some families really struggle to understand how to manage chronic disease when they don't have the sufficient language or literacy levels to be able to deal with things. And always having an interpreter with you doesn't always work out. It's not always available. So a refugee shared that someone here before us, they showed us a family doctor from Ethiopia. It's not that he's good or bad, but his language is close to ours. And he knows my language, I know his language. It's too hard to speak English for me. I still go to that doctor and I will never change. So it just illustrates that the ideal situation is where a newcomer can find a healthcare provider that speaks their language. Not always possible, but certainly a benefit where that is possible. And then sometimes kids come into the picture because they learn English a bit faster. And so the kids help with the disease management because the medication literacy piece around chronic disease is challenging for people with low levels of English or literacy. And this isn't always a good thing. There can be some power struggles resulting from that, and that, kids are kind of taking on a leadership role within the family, which comes up in this slide, that sometimes translation doesn't go well. And this is important medical stuff. So it's challenging. I see that a dynamic of a child that is 10 who comes with the mom to translate for the mom, and they fight because the mom thinks he's not saying the whole thing, and we don't accept that anymore. So as you can see, sometimes some parents rely on their children to come and translate for them during medical appointments, and it's not really the best thing. Children are not trained as translators, and the family dynamic may not be the best for that. So service limitations definitely mentioned by many newcomer families. So I go to the walk-in clinic when they are sick because it's closer to our area. Usually getting an appointment over at the primary care clinic is not easy. So that's why we usually go over here, the walk-in clinic. So you can see from this quote that they really value convenience because, they often don't have the transportation to go to faraway appointments. They may have a demanding work schedule. And so they have to get to healthcare when they can and how they can. So regarding navigation difficulty, this is an example of a family who struggled. A lot of people from the Burmese group and the Bhutanese group have glucose 6 phosphatase dehydrogenase deficiency. We made alert cards for these people. I gave the cards to parents who were very young and their child was very sick and ended up in the hospital. They gave him something, maybe prophylactic treatment for TB, and the kid almost died. And they didn't even call and ask me. He got hemolysis from the medication. So just an illustration that these parents probably thought that these are healthcare providers treating my child. And, they're in a place where they should know everything about my child. And just recognizing the authority of healthcare providers and maybe not feeling the agency within themselves to actually say, oh, maybe you should consider this, that my child has, this condition, thinking that, the healthcare providers should know this. And the results that can be very serious. It's not just a nice to know thing. So regarding cultural barriers, the capacity of our healthcare providers in recognizing and understanding the needs of newcomers and being able to adjust their practice in a way to support what those families might need requires additional time and resources, and not everybody is comfortable with that process or willing to invest in that time and energy that it takes to come alongside the needs that our newcomers arrive with. So just a recognition of how our healthcare system has ways of doing things and sometimes doesn't change very easily. And we need to reflect on that around how we can actually look for different opportunities to do things a bit differently. This quote really recognizes how cultural barriers directly impact clients. So one client said the doctor told her not to eat rice, just to eat brown bread. And she said even if she ate 10 bags of brown bread, she would still feel hungry for rice. If rice is one big plate, it would make her full, but not brown bread. It really illustrates the importance of clients' traditional eating practices, as with other traditional practices, that you really have to look at your own beliefs as a provider and think about your clients' beliefs within their culture and the importance of various things. In this case, it's food. So by not recognizing the importance of rice within the client's culture, the healthcare provider is providing advice that will likely not be used at all, that the client felt not even relevant really, and probably just ended up not being very helpful to anybody. So just emphasizes the results that could happen. So regarding access to health benefits, meaning those provincial benefits for low-cost drugs and such, when I was on social assistance, no big charges. Sometimes when I buy drugs, $1, $2, or $3, it's good. But I start to work, and after that I pay full charge. I didn't know about family health benefits. Now I have to pay for the amoxicillin for $20 or $40. I pay full charge, no more supplementary health benefits. So illustrating that when many refugees come, they are automatically eligible for supplementary health benefits that are tied to their social assistance. But as soon as they are off that, and if they aren't told, well, you need to register for family health benefits or for low-income benefits in other provinces, they may not do so. And so they have no idea that the next time they go to the drugstore, they're going to be charged a whole lot more for their prescription drugs. Just in illustrating that we have benefits, but newcomers need to be aware of them to use them. So this is a specific case of a client, a mother and son with HIV. So medication is very expensive and she has to pay 2%. So she's paying $149 every month for this medication. And that's coming out of her food allowance and her son's child tax credit. So by taking money out of those things to pay that, she's not having the money that she might use for healthy food or for other needs that her family might have. And this just recognizes that our health benefits programs, although useful, sometimes don't have the depth or breadth that people need to have good quality of life. So just moving from talking about barriers to how we can address these barriers, how we can increase access to healthcare. So similar to the other chart, this is kind of quantitatively looking at the number of responses that touched on various themes. And you can see that with both regards to both service providers and newcomers, they were both very supportive of developing responsive, accessible services to improve healthcare access. And then with regards to targeted newcomer services, some service providers mentioned that, as well as some newcomers around the need to develop specific services that target immigrants and refugees. And then there was also the other things mentioned around cultural competence, being aware of services, and engaging with newcomers to develop the appropriate services. So then there's a few slides about some quotes that illustrate these themes. So with regards to responsive, accessible services, we offered cab vouchers, tried to arrange group bookings so they're not having to come for another appointment, hired some interpreters that are on site, and email the interpreter to contact the client. So this just illustrates the extent that sometimes you need to go to have successful programs, meaning that you have to recognize the barriers that newcomers have around transportation, around not being able to come back for multiple appointments, about having some support with translation so that they can actually have effective communication with their healthcare provider. And the emailing to confirm things through the interpreter can be very helpful so that clients come to their appointments, they're fully aware and can make it. Again, regarding responsive services. So every summer we hold a kids active living and cooking club. And he wanted this little boy to attend it. And he said, "Oh yeah, great idea." And I gave him the phone number to pass on to his parents to phone in and register. He didn't show up the first day. So I phoned again to remind them, and okay, we asked to talk to the brother, and it was basically holding their hand to get this kid to come. And eventually he did and had a great time. So it's just the extra effort to follow up with people when they don't follow through with attending because maybe they didn't really understand what was required. And, by taking the initiative to talk to the brother instead of the parents to make sure that there was some understanding of what was actually being communicated, just another method to look at, who can really speak English well enough that I can communicate the idea with. There's various options there. A bit of information about how the referral needs to be coordinated. All the clients, even existing clients, for 2 to 3 years still have a language barrier and work through us. I am the primary person booking an appointment or making a referral to family physician and dental or eye appointments. They always put us as primary contact to coordinate the appointment with the specialist. So this is a quote from somebody who worked within Open Door who was assigned to coordinating medical appointments. And so by having that person be the actual primary contact with the specialist or healthcare provider was very helpful to these families because they wouldn't be able to communicate very well if the specialist tried to phone them directly. And so it's important to think about ways to share information because I know there's always concerns about who you can share information with. So as long as there's a consenting process so that everybody's aware of what's going on, it is possible to look at different ways of operating. With regards to cultural competence, perhaps we need some reflection on how prepared are we and what kind of skills do we have in actually meeting the needs of people, making sure that staff know how they can access interpretation services, and creating a culture where that is the first approach rather than just deferring to, "I don't know how to do that." Developing policies that actually ingrain this idea into our work culture to support our newcomers. So in some instances, there is translation or interpretation services available, but not everybody really knows how to use them. And maybe they don't have an easy access card that tells them what they should be doing. And so some proactive thinking about this and developing consistent operational procedures can be very helpful. So taking into consideration that cultural perspective that they're coming from and blending it to what we do here, it just benefits everyone in the long run. Exploring what it is within that culture, their beliefs around breastfeeding, for example, being active, or the Canada Food Guide, in the long run would be so powerful. So meaning that consider that there are other perspectives and other ways of doing things in different cultures that don't necessarily need to change, but maybe we need to consider how that fits into recommendations that we have in Canada. Like we have a food guide, and how do traditional foods fit into there that they can still be healthy? Just making sure that we're adapting how we're working so that it meets other cultures' needs. So just to sum up here around how we can increase access to healthcare, there was lots of support for developing responsive healthcare services, focusing on convenient access as core components of accessible healthcare. That newcomers preferred healthcare providers who could speak their language, but alternatively, we also have the option of providing consistent interpretation services. Service providers suggested that integrated primary healthcare sites that are not exclusively for newcomers, but that offer comprehensive services in a culturally appropriate manner could really be of good help, meaning that we don't need to develop primary healthcare sites that are like off by themselves and only for newcomers, but rather that we have healthcare sites that incorporate some of the components of culturally competent care to ensure that everybody's welcome and has their needs met. So I'd just like to acknowledge the many organizations that supported us through the study, and we'll welcome you for questions. So I'll stop sharing, and Andrew.
Thank you, Ginny and Hassan, for your very informative discussion. Understanding these nutritional needs and challenges that exist among newcomers, along with the very informative statistics and your case examples, have been very helpful to the audience today. And it's a topic that's of great importance when helping with newcomer health and nutrition. Again, thank you for sharing your knowledge and your experience. So let's move to the questions, and we've received a few. One question is, when there are issues or recognized possible issues of food insecurity among a patient or client, what do you recommend are the best steps to approach such a scenario while maintaining trust and respect to the patient or the client?
Ginny, would you like to take on it?
Oh, sure, I could start if you want. Okay, so I think that when you're seeing a client and it's come to your attention that there could be some food security concerns, I think it's important to have an open conversation with what kind of community supports are they accessing. Are they aware of some of the supports in the community that seem like they're being a burden on anybody, but just, are you aware of this particular support? That depends what community you're in. It could be a food bank, could be a place where they can go for community kitchens. Be aware of your community resources, which then can really help out. And if you do have to have access to a dietitian, they're very accustomed to then working with clients quite a bit on dietary issues. And so that's the optimal point, is you can refer them to your dietitian to get into a lot of the details. But not everybody has that. And so I think just being prepared to being able to explain what some of the community resources are that they could access and how to access those, because sometimes they can be a bit complicated.
Thank you. Is there any elements to add to that, Hassan?
I guess Ginny mentioned very well. Sometimes because of the issue of stigma, when we are talking about the food security of refugees, it's really hard to bring it to the agenda. And I think that's really recognition. The one side would be the settlement agencies, that they can do a school system. I have had talks in different community, in a series called Being Welcoming Community, and trying to engage people, different clubs within the city, and then having champions from refugees to engage in those kind of conversation to move forward. The health promotion, a set of health promotion initiatives that moving from the community. The other side, one of my PhD students right now is looking into policy items that we should have, looking into the policy items to see that, do we have any specific policy item related to food security status of refugees in Canada? And then the short answer is that no. So then I think that all the activities coming from the community level, all health promotion initiatives are helpful, but the other side, there should be some policy changes as well.
Thank you. One of the questions we have is there a role for increasing awareness of appropriate diet and nutrition through school programs?
That's a very good question, and we had interest in that. We started such initiative, going to the schools, talking to the board of directors, and then also trying to find some ways of increasing awareness and perhaps bringing into the curriculum. working with the refugees and immigrants in the school system themselves. So one of our projects was kind of having voices in vision, bringing them to express what they can do themselves, what are the likes and dislikes that they have, what they see related to issues on food, health, and so on. It was very good, and then empowering for them, kind of bringing them to the level of confidence to talk about the issues that they have and the way that they think about the new community. But all of those, again, I am a researcher and also house promoter. I'm working at this level. There should be a kind of concerted effort, bringing those issues to the curriculum, bringing cultural competency to the schools, bringing those notions, kind of translating what we found into action items that can go to the school system. As an example, in Saskatchewan, I don't know about other cities, Open Door Society, biggest settlement agency, came up with the idea of, they call it switch program, working with the school system so that they bring the issues that newcomer families are facing with to the school teachers and administrators so that they are aware of it and take kind of a joint set of actions on that. Yes, there are good activities going on in short, but again, there should be a good concerted effort.
Okay, good. Just looking at the time, I think we just have enough time for one more quick question. So what is next for your research? What sort of opportunities is your team looking towards in the future with future research?
I think a lot of our results point to the possible need for some specialized health promotion among newcomer families. And so I think there's opportunities to use the results that we've noted to actually develop some model programs. And so we haven't actually moved to the stage of testing any model programs, but that would be one of the things we could do moving forward.
And thanks, Ginny. Well said. I need to add this that then understanding that what is happening in refugees is common in many other countries. In terms of next move, what we decided to do, we came up with the idea of bringing on board different, say, researchers, community-based organizations, even UN agencies to work together to look into the solutions to food security issues that refugees are facing. We are hoping that we can have a kind of a global, a kind of a set of efforts on finding best practices around the globe and solutions. As the first step, we came up with a scoping review that we are specifically on interventions that are happening right now, identifying interventions in different levels, different countries, and ranking them and seeing, okay, so in a setting like, say, Canada, what are the best intervention can work, learning from each other.
Good. Thank you. So yeah, thank you again for our speakers for taking the time to participate in today's presentation. And thank you to you, the audience, for joining us today. You're very welcome to join us again for our upcoming events, such as on April 7th. We have learning more about vaccine hesitancy in these pandemic times with Dr. Laurence Monet. And on April 28th, we have a panel discussion on preparing for COVID-19 vaccination. And before I sign off, are there any final words from Dr. Lane or Dr. Vatanparast?
I appreciate everyone's attendance and interest in this subject because it's certainly important, I think, to look at how we can adjust our healthcare system to better meet the needs.
Just echoing Ginny's voice.
Thank you. So following today's session, you'll be invited to complete a survey to share your feedback with N4. These surveys help us continuously improve and seek out new webinar content and opportunities that are responsive to topics that you're interested in. We kindly ask that you complete this brief survey after this presentation has ended, either being directed right after this presentation or by following the link in the chat. If you missed any part of today's presentation or would like to watch this session again, we'll be posting the recording to our N4 platform within the next 24 to 48 hours, so by Monday or Tuesday next week. Our speakers will also be answering your questions related to the webinar for up to 10 days following the webinar in the meeting place on the N4 platform. So please sign up today at newcomernavigation.ca for all our resources and access to future webinars and meeting place content. Thank you, everyone, and we will see you online again at a future NVOR event. Take care and goodbye.